This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. My name is Peter Sloan, and I am one of the course directors for Cardiology Academy. I would like to introduce our speaker, Dr. Nimesh Shah, who is currently the Medical Director of the Cardiovascular Intensive Care Unit at MedStar Union Memorial Hospital in Baltimore, Maryland, who will provide an overview of cardiopulmonary bypass.
Before we can begin to discuss the ICU management of the post-cardiotomy patient, meaning patients who have had open heart surgery, we first need to understand the general conduct of heart surgery. In order for heart surgeons to see and perform the intricate surgery on or inside the heart, the operative field has to be bloodless, and usually the beating heart needs to be temporarily motionless. This is accomplished by using a cardiopulmonary bypass machine in the operating room. It's relevant to us as ICU practitioners since its physiologic consequences manifest postoperatively in the cardiovascular ICU. So let's discuss how cardiopulmonary bypass works. On the right, you can see what a cardiopulmonary bypass machine looks like. At its core, its goals are to circulate blood for the heart, exchange oxygen and carbon dioxide for the lungs, and to deliver cardioplegia solution to arrest the heart. The operation and management of this machine requires years of training by a specialist called perfusionists, whose sole job is to manage and troubleshoot this machine in the operating room. On the left side is a diagram of the cardiopulmonary circuit. It looks very intimidating, but we'll go through it together. The cardiopulmonary bypass machine draws blood from a large cannula directed in the vena cava just before the heart. Additionally, blood is drawn from a sucker, which is used to collect blood from the operative field, as well as chamber vents, which I'll explain shortly. All of this blood is directed into a venous reservoir. The blood is eventually pumped into a membrane oxygenator. The function of this oxygenator is to infuse oxygen as well as remove carbon dioxide. This oxygenated blood is then pumped into tubing and into a cannula that is directed into the ascending aorta. There's also another pump used to infuse cardioplegia solution directly into the aortic root. Metabolically active myocytes without oxygen supply can result in myocardial ischemia and cardiac dysfunction. In order to avoid cardiac injury and also allow motionless heart for surgery, cardioplegia solution is utilized. The solution is cool with high amounts of potassium usually that's infused directly into the aortic root cannula, and it protects the heart from ischemia. Usually this is delivered antegrade, meaning through the ascending aorta into the coronary arteries. However, sometimes there's blockages of the coronary arteries and the venous system can be utilized. Retrograde cardioplegia is introduced through a catheter that is directed through the free wall of the right ventricle into the coronary sinus using tactile feel by the surgeon as well as TE guidance. This allows the myocytes to get some protection using the venous system of the heart. It is important to know that the rotors in the cardiopulmonary bypass machine create continuous flow as it enters the ascending aorta. With the cardioplegia solution, this results in asystole on the telemetry, as well as a flat line arterial tracing without a systolic or diastolic pressure, but usually there is a mean arterial pressure. Also, the blood interface with the tubing and the components of the machine are very thrombotic. Thus, cardiopulmonary bypass requires high amounts of anticoagulation, and heparin in the order of 30 to 80,000 units can be given for surgeries to avoid clotting of the circuit. Additionally, patients are typically kept cool, and the heart is kept cool to avoid ischemia. Cardiopulmonary bypass has important physiological consequences for the clinicians in the ICU. Blood contact with the cardiopulmonary circuit, in addition to the trauma of cardiac surgery in itself, causes a large activation of inflammatory cells, also leading to thrombosis. Thus, large amounts of anticoagulation are required to conduct a cardiopulmonary bypass. As one can expect, bleeding is a potential complication after heart surgery related to the anticoagulation, as well as dysfunction of the coagulation system, both from consumption of factors, hypothermia, and platelet aggregation onto the circuit surfaces. Additionally, complement activation causes an inflammatory response, resulting in vasodilation, hypovolemia with third space fluids, as well as potential end organ dysfunction. Depending on how well the cardioplegia solution can penetrate into the myocytes, there may be some cardiac dysfunction related to that, as well as ischemia reperfusion.
If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.